duration between the Q wave and the height of R wave, it is more than 40 milliseconds. It means so the muscle depolarization is getting delayed. So it is because of ischemia. So this is a very early sign. So when the patient is just present with chest pain, you can see this ventricular activation time. So this is nothing but the activation of the patient myocardium from the endocardium to epicardial activation is the ventricular activation time. On the surface ECG, you can see as due to peak of the R wave. So this is intrinsicoid deflection. So if it is more than 40 milliseconds, means that the patient is have some abnormality in the depolarization. So whenever you suspect a ischemia, then it is the cause. So this is one of the earliest sign in hyperacute MI. And the next one is increase. So this is what is seen in the hyperacute mind. So initially there will be slight depression in the ST depression, and here you can see. So this is the genesis of the Q wave to peak of the R wave, and it is around 60 milliseconds. So this is increase in the anticipated deflection and increase in the R wave amplitude, and then the ST elevation. Slowly, how it evolves. So initially, the increase the amplitude of the R wave slowly get diminished. The ST elevation gets diminished, and then the Q wave is becoming prominent, and finally it will like Q with diminished ST segment with T inversion. This is how the MI evolves. So initially the R wave amplitude gets prominent, followed by ST segment elevation, and then loss of R wave amplitude, ST segment getting segment elevation getting diminished, and then the genesis of T wave. This is how the ischemic cascade evolves in hyperacute MI. So now I'll show some ECGs. So this two days back, I have seen one case. This is around 2:30 a.m. So that patient is a 52 years male, diabetic, hypertensive, CKD. He had some rheumatoid arthritis, so multiple comorbidities, morbid obesity. He stays in our apartment. So at 2:30, I got calling bell ring. So I got that patient is lying on the floor. So he woke up for washroom, and from then onwards he is having classical angina. He placed his chest, fist on the chest, and he lied on the floor. So I thought, oh, so this is definitely angina, and the duration is 30 minutes. So immediately I took him to KIMS, and this is the first ECG. So what you are seeing in this ECG? So first, whenever you suspect ECG, whenever you suspected MI, first look for ST elevations. So there are no ST elevations, and you look for territory wise. So either inferior MI or anterior MI. So these 2-3 AVF, there are no elevations. Then simple V1, V2. Here in V1, see what is there? That T wave, yeah, ST elevation is there, and the T wave is more prominent. So normally, what is prominent T wave? So it is not more than R wave. So normally, the T wave amplitude is more than 1/8 of the R wave and less than 2/3 of the R wave. So that because many that amplitude of the T wave varies from individual to individual. Some patients, lean individuals, they have more amplitude, and obese or female will get because of the more fat. You will have less amplitude T waves. But the definition of tall T is the amplitude of T wave is more than 50% of the preceding R wave. So here the T wave is almost more than R wave. So this is, and normally what I said, the T wave in the V1 is inverted. So here you can see a biphasic positive T wave, and you have hyperacute in V2. So you can take it as a contiguous change, and it is in the patient, and there are 1 mm depressions in the 2, 3, and AVF. What we call it as reciprocal STT changes. So normally the axis is like that because you have surface ECGs and you have limb leads. So when there is ST elevation in one lead, there should be a reciprocal change in the opposite lead because the vector is like that. So it is when it is away from the ischemic zone and you are picking a ST elevation in that zone, there should be a ST depression in the reciprocal leads. So here you can see there are ST depressions 2-3 areas. So in the because it is around 230, so and because of comorbidities, and if patient is in hyperacute phase, I thought I would thrombolize. So immediately I got Trinity place. So and I gave to the patient. So within 15 minutes, 70% of the pain got subsided. But because of interest, I did ECG just within 15 minutes. So this is the second ECG. Just 15 minutes after starting of giving a thrombolysis. Normally it will take time, minimum 1 hour or 90 minutes for elevation to subside. So within 15 minutes you can see clearly there are ST elevation, prominent ST elevations in V1 to almost V5 and lead 1 AVL with reciprocal changes. So this is extensive anterior ST elevation MI. So where we can pick too early in the hyperactive phase. This is prominent T waves. So that's why that is very important. So you should know each phase of STT changes in ST elevation MI. So initially there will be prominent T waves followed by ST elevation. So this patient, by the time I saw, because pain is just 30 minutes duration. But when I put a echo pro, the patient had severe LV dysfunction. So in ischemic cascade, before the onset of symptoms, before the onset of ECG changes, after the symptoms, you will see regional wall motion abnormality. That is the first change subjectively we can see is echo. So echo wise, there will be regional wall motion abnormality followed by ST elevations you will see. So that patient had severe LV dysfunction, and so this is the 15 minutes, and this is about half an hour, and this is 1 hour. That is post thrombolysis, completely pain free, and where this here you can see there is complete resolution of ST segment. And I said what I said in the ischemic cascade. So the presence of R wave, it indicates that there is significantly viable myocardium. So here, so all the STs got resolution, and there are T wave inversions. So the patient still have ischemia. That is he had critical narrowing, but the muscle is viable because there are R waves. So this is how we judge clinically before going for angio. I thought, okay, this patient got benefited with thrombolysis, and I did angio on the next day. That patient had severe calcific disease. So I thought, okay, so I took a good decision because not going for primary, because this is the patient where if I go to primary, then I will stuck up because it is a heavily calcified vessels, because he got significant comorbidities, hypertension, diabetic, CKD, morbid obesity, RA, because all it is a high inflammatory state. So he had significantly calcified vessel. So that is how ECG helps in taking decision also. So most of the times, when I was and in the hyperacute phase, that is very important in the hyperacute phase. In the first 1 or 2 hours, so the patient comes to me, and these comorbidities, even thrombolysis is equally effective. So that is how